We are diving deep into what is arguably the core structural defense system of your entire body, the anterior abdominal wall.
Right.
This is not just tissue. It's a multi-layered dynamic corset whose structural integrity dictates everything from your capacity to lift objects to how your internal organs are protected.
Indeed. We are moving beyond the superficial understanding today. Our mission, based on highly detailed anatomical sources, specifically Chapter 60 on the anterior abdominal wall, is to dissect every single component, every linen, as you put it, to truly understand the sophisticated engineering.
The engineering, yeah.
The structure, the precise function, the incredibly rich vascular network, and critically, why this region harbors the most common sites of structural failure, hernias.
I think the biggest challenge for our learner audience is connecting this dense nomenclature, things like the transverse isthmosalis fascia or the arcuate line, to their everyday life. Why should a well-informed person who isn't a surgeon spend an hour with us wading through the layers of the abdominal wall?
Because this wall is the definition of core function. It's absolutely fundamental to stability, and most importantly, the dynamic regulation of intra-abdominal pressure, or IAP.
IAP.
Whether you are performing a heavy squat, sustaining a forceful cough, pushing during childbirth, or just achieving forced expiration during exercise, it is the coordinated action of these muscles and the integrated strength of their fascial supports that allow you to generate and manage that immense pressure.
So it's all about managing pressure.
It is. If you lose the integrity of even one layer, the system fails. Understanding the individual components reveals why the wall is so strong where it needs to be and why certain necessary passages create unavoidable points of structural vulnerability.
That concept of necessary vulnerability is fascinating. So we're going to build this wall from the outside in.
From the skin inwards.
We start with the surface, the skin and the surprisingly complex split fascial layers, then move to the dynamic engine, the powerful crisscrossing muscles, trace the hidden network of vessels and nerves, and finally dedicate significant time to the structural weak spot, the inguinal region, and the resulting mechanical failures.
That's the plan. It's a journey from the outside in.
Let's begin our construction at the surface. When you look at the abdomen, how many layers are actually protecting the vital organs beneath? It seems simple, but our sources indicate that complexity begins immediately beneath the skin.
It does. We're discussing a large curved area, the anterolateral abdominal wall, which extends superiorly from the costal margin and the xiphoid process.
Okay, so the bottom of the ribs.
Exactly. And it wraps down and around to the pubic symphysis, the iliac crests, and the inguinal ligaments inferiorly. The skin itself, while variable in thickness and features, serves as the initial flexible barrier.
Right below the skin, we hit the subcutaneous tissue, which is, commonly known as fat.
Yes, the soft tissue layer. Its thickness is highly individualized, varying based on genetics, gender, body habitus, and nutritional state. Beyond insulation and padding, this layer allows the skin a great deal of mobility over the deeper structures, which is critical for movement and deep respiration.
But this layer isn't a single amorphous mass, particularly below the level of the umbilicus. This is where the superficial fascia develops its split personality.
That's correct. That's a great way to describe it. Inferior to the umbilicus, the superficial fascia clearly divides into two distinct layers. The fatty layer, known as Camper's fascia, and the membranous layer, known as Scarpa's fascia. And this division is critical, and its attachments dictate the path of fluids in a way that is immediately, life-saving.
Okay, let's start with Camper's fascia, the thick, fatty layer.
Camper's is essentially the storage and padding layer. Superiorly, it remains continuous with the superficial fascia over the rest of the trunk and chest.
So it's all connected up top.
It is. Inferiorly, it extends down into the perineum and the external genitalia. As noted in the sources, in females, this layer can sometimes incorporate smooth muscle fibers, functionally connecting it to the underlying dartos layer of the labia majora. It's thick, loosely attached, and highly mobile.
And immediately deep to that, we encounter the key structural membrane, Scarpa's fascia. The sources describe this as dense, thick, and composed of strong collagen and elastic fibers. This feels engineered.
It absolutely is engineered, primarily due to its anchors. Unlike the loose, fatty Camper's fascia, Scarpa's is firmly tethered to the underlying musculoskeletal structures.
Right.
Superiorly, it fuses with the deep fascia covering the trunk. Medially, it has strong attachments to the central tendon of the abdomen, the linea alba, and the pubic symphysis.
Now let's talk about the most crucial anchoring point for clinical practice.
Yeah.
Its inferior attachment.
Inferiorly, Scarpa's fascia is engineered to be a non-negotiable barrier. It fuses firmly with the fascia lata, that is the deep fascia of the thigh.
Fascia lata, okay.
Distal to the inguinal ligament and the pubic tubercle. This fusion means Scarpa's fascia acts as a structural dam, preventing any fluid that collects in the superficial space from simply sliding down the leg.
Wait, if I'm visualizing this, that means any fluid or leakage that occurs deep to the skin, but superficial to the muscles, is physically walled off from the lower limbs.
That's it.
That specific fusion point to the thigh fascia is the nugget that saves lives, isn't it?
It is the clinical nugget that defines the surgical approach in trauma. Consider the extreme scenario. A patient suffers significant pelvic trauma, perhaps a severe contusion or fracture, resulting in the rupture of the urethra.
Okay.
Blood or urine extravasates out of the pelvic region. Because the Scarpa's fascia is so strongly anchored to the thigh fascia, the fascia lata, the fluid cannot move inferiorly past the groin crease.
It's blocked.
It is contained and forced to track along paths of least resistance, superiorly onto the anterior abdominal wall, and inferiorly and medially into the scrotum and the penis.
So Scarpa's fascia acts like a dense internal hazmat barrier, dictating the predictable path of fluid accumulation. It prevents potentially infectious or irritating fluids from infiltrating the entire lower extremity, confining the problem to the trunk and genitalia where it can be managed. That's a powerful defense mechanism built into a seemingly simple membrane.
It proves that sometimes the simplest-looking layers perform the most vital barrier function. Now, moving deeper, beyond the superficial layers, we reach the deep fascia.
The deep fascia.
This is a much thinner, less impressive layer covering the external oblique muscle. It's highly variable, often nearly undetectable in very lean individuals, but more pronounced in others.
And then we hit the true inner lining, the transversalis fascia. This feels like the final structural layer before we reach the abdominal contents themselves.
It is the definitive inner wall. The transversalis fascia is a thin but robust sheet of connective tissue that lines the deep surface of the transversus abdominis muscle, separating the deep musculature from the extraperitoneal fat. Its structural importance cannot be overstated.
Tell us about its connections and its role in stabilization.
It is a continuous lining. Superiorly, it fuses with the fascia covering the diaphragm, and inferiorly, it anchors to the iliac crest and the deep aspect of the inguinal ligament.
Okay.
Crucially, the deepest part of the inguinal region, the deep inguinal ring, is merely an opening in the transversalis fascia, which is why it plays a massive role in hernia formation.
And how does it interact with the structures passing through the wall?
As the spermatic cord or the round ligament passes through the deep ring, the transversalis fascia is dragged along with it, forming the innermost fascial covering of those structures, the internal spermatic fascia.
So it contributes a layer.
It does. This emphasizes that the transversalis fascia is the last, thin, continuous layer of integrity that holds the abdominal pressure back before you hit the layer of fat.
Speaking of that fat, the next deepest layer is the extraperitoneal connective tissue.
This is the layer that sits directly between the transversalis fascia and the final innermost membrane, the parietal peritoneum. It contains a variable amount of fat and vessels, depending on the individual.
Why is this thin, fatty layer so important in modern medicine?
Its importance is purely surgical. This extraperitoneal space is the primary working area for modern laparoscopic hernia repair techniques, often called preperitoneal repair.
Laparoscopic, right.
Surgeons prefer to dissect and place mesh within this space, effectively bolstering the weakened transversalis fascia from the inside out without having to enter the abdominal cavity.
The peritoneal space itself.
Exactly. This is less invasive and reduces surgical risks, but it means that the surgeon's orientation in this specific layer is absolutely critical.
So in summary, we have built the envelope, a flexible outer layer, skin and campers, a critical barrier layer, scarpas, that dictates fluid paths, a deep wrapping, deep fascia, and finally, the essential inner lining, transversalis fascia and extraperitoneal fat, that defines the structural boundary and is the target of modern surgical repair.
Precisely. It's a sophisticated system of engineering, not just skin and fat, but complex functional sheets designed for containment and structural support.
Now that we've covered the static protective envelope, we move to the dynamic engine of the abdominal wall. These are the muscles responsible for generating movement, providing posture, and of course, that key function of pressure regulation.
The anterolateral abdominal muscles are neatly divided into 5 main players. 3 flat, sheet-like muscles, the external oblique, internal oblique, and transversus abdominis, and 2 vertical muscles, the rectus abdominis and the small pyramidalis.
Before we detail each one, let's underscore their general function beyond just core strength. The ability to generate intra-abdominal pressure, IAP, is central.
IAP is the force generated within the abdominal cavity when the wall contracts. It's essential for stability. When these muscles contract simultaneously, they turn the torso into a rigid cylinder, aiding in trunk flexion and resisting excessive extension.
Like a natural weightlifting belt.
Exactly. Think of powerlifters wrapping their core before a heavy lift. They are stabilizing the spine by consciously maximizing IAP. It's also vital for involuntary functions, like increasing pressure for forceful exhalation, expelling contents during defecation, or delivering a baby.
And the absence of that function leads directly to structural risk.
Absolutely. The primary job of these muscles, even when you're just standing, is to maintain constant muscle tone. This constant low-level tension keeps the abdominal wall taut and flat.
Right.
If that tone is lost, say due to nerve injury or congenital absence, the flaccid wall immediately bulges outward, drastically increasing the chance of herniation. The integrity of the wall is structural, but its stability is dynamic and relies on constant muscle activity.
Let's start with the most famous of the group, the central powerhouse, the rectus abdominis.
It is the paired, long, strap-like muscle running vertically from the pelvis to the chest. It originates inferiorly from the pubis and pubic crest and inserts superiorly onto the xiphoid process and the costal cartilages of the 5th, 6th, and 7th ribs.
Visually, what defines the rectus abdominis is the segmentation, the so-called six-pack. These segments are the tendinous intersections.
These are fibrous bands that cross the muscle belly. Typically, there are 3. One often near the xiphoid process, one at the umbilicus, and one midway between them.
Okay.
They anchor the rectus muscle to the anterior portion of its enveloping sheath. Because the muscle fibers are contained between these intersections, they provide the segmented look. They also divide the muscle functionally, though it contracts as a whole unit.
And the muscle's deep blood supply is key for surgical planning.
It has a crucial dual supply, primarily via the superior and inferior epigastric arteries, which run deep to the muscle within its sheath. Its innervation comes from the lower 6 thoracic spinal nerves, which we will detail later.
Now we get to the geometry challenge, the rectus sheath anatomy. This isn't a simple bag, it's a dynamic, interwoven structure that changes its architectural design dramatically halfway down the abdomen.
Yes.
It's formed by the fusing aponeuroses of the 3 flat abdominal muscles.
This architectural change is the most important anatomical detail for understanding structural weakness. The demarcation line for this change is the arcuate line, usually situated midway between the umbilicus and the pubic symphysis.
Walk us through the superior half above the arcuate line. How is the rectus abdominis so incredibly protected there?
The superior half is the strongest section, engineered like a braided rope. The aponeurosis of the internal oblique muscle splits. One layer passes anteriorly to the rectus, and one layer passes posteriorly.
Oh, it splits around it.
It does. Then the external oblique aponeurosis joins the anterior layer, and the transversus abdominis aponeurosis joins the posterior layer.
So above the line, the rectus muscle is fully encapsulated by tough, interwoven aponeurotic tissue on both sides. It's got a front and a back wall.
Exactly. It's a double reinforced shield.
But then we hit the arcuate line, a curved, sharp, sometimes indistinct line, and the structure abruptly fails posteriorly. What happens below that line?
The architectural shift is stark. Below the arcuate line, all 3 aponeuroses, external oblique, internal oblique, and transversus abdominis pass entirely anterior to the rectus abdominis muscle.
All 3.
All 3. They form a single, thick anterior shield.
And if they all shift to the front, what is left posteriorly? What is the last line of defense against the high pressure of the abdominal cavity in that crucial lower segment?
Only the thin transversalis fascia and the small layer of extraperitoneal fat.
That's it.
That's it. The robust aponeurotic shield disappears completely posteriorly. You can think of it like this. Above the arcuate line, the structure is reinforced concrete. Below the arcuate line, the structure is a strong door held in place only by a thin layer of plywood.
Wow, that dramatically explains the vulnerability of the lower abdominal wall. That inherent structural weakness below the arcuate line is why surgeons treat that area with exceptional caution.
It dictates many approaches. If you need to make an incision in the lower abdomen, you are crossing a region that lacks the natural muscular reinforcement found higher up. Any defect here relies almost entirely on the integrity of the transversalis fascia, which is why chronic strain can easily lead to failure in this segment.
Now let's look at the three flat muscles that create this sheath, starting with the outermost, the external oblique muscle.
The external oblique is the largest and most superficial. Its fibers run inferiorly and medially, the classic hands in pockets direction.
Hands in pockets, right?
It originates from the lower 8 ribs, and its vast aponeurosis spreads medially, inserting into the linea alba, iliac crest, and pubic tubercle. Its action contributes to trunk flexion and contralateral rotation.
And its famous inferior margin.
The inguinal ligament. This is simply the heavily reinforced, folded-back inferior margin of the external oblique aponeurosis, running between the anterior superior iliac spine and the pubic tubercle. It forms the foundation, or the floor, of the inguinal canal. It's important to remember it's not parallel to the floor. It dips down as it runs medially.
Moving inward, we find the middle layer, the internal oblique muscle. Its fibers generally run superiorly and medially, perpendicular to the external oblique, forming a powerful crosshatch structure.
The perpendicular fiber direction is key to rotational stability. The internal oblique is thinner, and its complexity, as we noted, is in its aponeurosis splitting superiorly to form the rectus sheath. But inferiorly, it performs a second vital function, contributing to the conjoint tendon.
Explain the conjoint tendon, or a falx inguinalis, again, as it's the structural buttress of the most vulnerable region.
The conjoint tendon is the fused structure of the inferior aponeuroses of the internal oblique and the deepest muscle, the transversus abdominis.
Okay, so a fusion of the bottom two.
Right. These fibers arch over the structures in the inguinal canal, the spermatic cord or round ligament, and attach densely to the pubic crest and pecten pubis. This dense, fixed attachment provides critical, active reinforcement to the medial third of the posterior wall of the inguinal canal, directly counteracting the pressure that causes direct hernias.
Finally, the deepest flat muscle, the transversus abdominis muscle.
As the name implies, its fibers run predominantly horizontally, acting like a deep internal corset or girdle.
The corset muscle.
That's the one. It originates from the thoracolumbar fascia, the iliac crest, and the costal cartilages. Its action is primarily tonic, generating that constant, stabilizing intra-abdominal pressure. It is the core stabilizer, responsible for the corset effect that prevents the abdomen from simply distending outward under strain.
Before we move on, we have to mention the highly variable and functionally minimal pyramidalis muscle.
The pyramidalis is truly the anatomical footnote. It's a small, triangular muscle located inside the rectus sheath near the pubic crest. It's absent in about 20% of people.
1 in 5.
And even when present, its function is largely limited to tensing the linea alba. Its presence or absence has virtually no impact on stability, which is interesting when considering the massive stresses that lower segment endures.
So we have this incredible three-ply weave of muscles, external oblique, internal oblique, and transversus abdominis, all crisscrossing and wrapped up in a sheath that strategically disappears posteriorly below the middle of the abdomen. This system is strong, but it requires fuel and instruction. Here's where the structure gets its life support. We established that the abdominal wall has an incredibly rich, redundant vascular network. This isn't accidental. It's a design choice for survival and surgical redundancy. Let's trace the crucial connections.
The blood supply is defined by two major deep arterial systems that meet and anastomose within the rectus sheath, providing a vast collateral highway. We're talking about the superior and inferior epigastric arteries and veins.
Starting superiorly, the superior epigastric artery comes down from the chest.
Correct. It is the terminal branch of the internal thoracic artery, a branch off the subclavian system. It descends, passing posterior to the rectus abdominis muscle, supplying the upper abdomen and running deep within the rectus sheath until it links up with the inferior counterpart.
And traveling up from the pelvis, the inferior epigastric artery.
This vessel originates directly from the external iliac artery, very close to the inguinal ligament. It courses upwards, piercing the transversalis fascia, entering the rectus sheath, and ascending deep to the rectus abdominis. It then performs the critical link, the anastomosis, with the superior branch.
So if the external iliac artery were blocked, the abdominal wall could potentially receive blood flow retrogradely from the subclavian artery through this connection and vice versa.
Yes.
This anastomosis creates a high-pressure, life-saving collateral route.
That is the essential insight. This system bypasses major trunk vessels. Surgeons must recognize that these are high-pressure vessels, and injury leads to significant blood loss.
Beyond this main vertical connection, what other deep branches contribute to this redundancy?
The inferior epigastric artery is a busy intersection. It gives off branches that connect with the deep circumflex iliac artery, which also arises from the external iliac. Even more dangerously, its pubic branch often connects with the obturator artery.
Okay.
This specific anastomosis is sometimes called the corona mortis, literally, the crown of death.
The crown of death, that's memorable.
It is due to its variable, often exposed position deep in the pelvis. If that vascular connection is severed during deep pelvic surgery or trauma, it can be extremely difficult to access and ligate, leading to rapid catastrophic hemorrhage.
That name alone implies the gravity of getting that area wrong. Now, focusing on the inferior epigastric artery's exact location relative to the deep inguinal ring, why is this detail paramount?
It is the defining anatomical landmark for hernia classification. The inferior epigastric vessels run consistently medial to the deep inguinal ring.
Medial.
This means that if abdominal contents enter the deep ring, they are lateral to the vessels. That's an indirect hernia. If they push directly through the posterior wall, they are medial to the vessels, a direct hernia.
I see.
Surgeons use this relationship as their map during repair. Furthermore, the sources emphasize the inferior epigastric artery's large diameter, up to 3 millimeters, confirming it as a major conduit, not a minor feeder.
This high-pressure system also has visible clinical manifestations on the venous side when the liver fails. We talked about portal hypertension.
When liver disease, such as cirrhosis, causes back pressure in the portal venous system, that pressure seeks collateral routes to return to the systemic circulation. The veins surrounding the umbilicus, which normally provide a minor connection between the portal system and the systemic system, become massively dilated. This visual symptom is the radiating pattern of enlarged veins known as caput medusae.
It's named for the Gorgon's snake hair, but it represents the body attempting a life-saving bypass.
Precisely. It is a vital, naturally formed porticaval shunt, diverting blood flow around the blocked liver and back to the heart. It's a powerful sign that the body's collateral circulation has been activated due to systemic pressure failure.
Let's talk about the lateral and segmental supply from the intercostal, subcostal, and lumbar vessels.
These vessels provide the segmental supply to the sides and back of the abdominal wall. The lower intercostal vessels, the subcostal vessels, and the upper lumbar arteries run forward, piercing the oblique muscles and providing localized blood flow. They are also integral to the anastomosis, connecting the systemic circulation laterally before linking into the epigastric system centrally.
Now on to the lymphatic drainage. How do the fluids drain from this large surface area?
Lymphatic drainage is split distinctly at the level of the umbilicus.
The umbilicus is the dividing line.
It is. Lymphatics above the umbilicus generally track superiorly, draining into the axillary and peristernal nodes. Lymphatics below the umbilicus drain inferiorly to the most important superficial concentration, the superficial inguinal nodes.
So, an infection or cancer originating in the skin of the lower abdomen or genitalia would primarily drain to the groin area first.
That's right. For the deep lymphatics, they follow the major deep arteries, like the inferior epigastric, to the external iliac nodes, eventually merging into the lateral aortic nodes deep within the abdomen.
Finally, the segmental nerves, the wiring that powers the muscles and provides sensation.
The abdominal wall is segmentally innervated by the ventral rami of the lower 6 thoracic spinal nerves, T6 through T12, and the first lumbar nerve, L1, which includes the iliohypogastric and ilioinguinal nerves.
And where do they run? This plane is crucial for avoiding surgical injury.
This is a critical anatomical detail known as the neurovascular plane. All these nerves and their associated vessels run in the plane situated between the internal oblique and the transversus abdominis muscles.
Between the bottom two layers again?
Yes. They pierce the aponeuroses anteriorly to reach the rectus sheath and supply the skin.
We need to nail down the dermatomes, the sensory map of the skin.
P6 through T9 supply the skin and muscle in the upper abdomen. The T10 nerve is the gold standard landmark, providing sensation specifically at the level of the umbilicus.
T10, umbilicus, got it.
T11, T12, the subcostal nerve, and L1 supply the lower abdominal wall and the groin region. Specifically, the L1 branches, the iliohypogastric and ilioinguinal nerves, supply the skin of the lower abdomen and portions of the genitalia.
So if a patient undergoes lower abdominal or inguinal surgery and reports a patch of permanent numbness or chronic neuropathic pain in the groin or inner thigh, that immediately directs suspicion toward accidental entrapment or injury to the T12 or L1 nerves,
Exactly.
which is a common and debilitating complication.
It is. Knowing the precise course of these nerves, particularly the L1 branches as they emerge from the musculature to pass through the inguinal region, is fundamental to minimize chronic post-surgical pain.
We have meticulously detailed the structure and its life support system, emphasizing the robustness of the core. But now we must confront the unavoidable compromise. The inguinal region. This is the anatomical gateway. And because structures must pass through the abdominal wall, it creates the structurally weak passage known as the inguinal canal.
The inguinal region accounts for the vast majority of abdominal wall failures. The canal exists purely for developmental reasons. The testes descend through the layers of the abdominal wall into the scrotums in males,
Right.
dragging with them fascial coverings and blood vessels, thus creating a permanent oblique channel. In females, the round ligament of the uterus passes through the same channel.
Let's define the inguinal canal again.
It's an oblique tunnel, approximately 3 to 6 centimeters long in an adult, running downwards and medially. The contents, the spermatic cord or round ligament and the accompanying nerves rely entirely on the surrounding walls for protection.
The crucial defense mechanism is the oblique nature of the canal, forcing the contents to travel at an angle, increasing resistance. This tunnel is defined by two openings, the entrance and the exit, known as the rings.
The entrance, located superiorly and laterally, is the deep inguinal ring. This is not a clearly defined fibrous ring, but rather an opening or deficiency in the transversalis fascia, that innermost fibrous lining.
Just a hole in that fascia.
Pretty much. It is often slightly reinforced by the interfoveolar ligament.
And we must revisit the relationship with the key blood vessel here.
The deep ring is always situated lateral to the inferior epigastric vessels. This is the lateral boundary of that critical area known as Hesselbach's triangle.
The exit, located inferiorly and medially, is the superficial inguinal ring.
The superficial ring is a distinctly V-shaped defect, an actual tear or opening in the massive aponeurosis of the external oblique muscle.
The outermost muscle this time.
Correct. It's located just above the pubic tubercle. It is bounded by tendinous bands, the medial and lateral crura, and is minimally reinforced by intercrural fibers, which attempt to prevent it from simply tearing open wider under pressure.
To understand how this gateway resists pressure, we need to know the construction of its four walls. This is where the aponeuroses we discussed in Section 2 come together to form the tunnel.
We can simplify the boundaries by thinking about their composition. The anterior wall is the simplest. It is formed primarily by the aponeurosis of the external oblique muscle.
Okay.
But inferiorly, the lateral third gains reinforcement from the underlying internal oblique muscle fibers.
The posterior wall is the most critical defensive layer, facing the direct intra-abdominal pressure.
The posterior wall is the primary weak point. It is formed by the thin but continuous transversalis fascia. However, the medial third of this posterior wall is strongly reinforced by the dense fibrous structure we discussed, the conjoint tendon.
Right, the fused tendon.
That reinforcement is what protects against direct hernias.
So we have the thin transversalis fascia over the medial two-thirds and the conjoint tendon buttressing the medial third. What creates the arching roof of the canal?
The roof is created by the arching inferior fibers of the internal oblique and transversus abdominis muscles as they course over the canal contents and meet medially to form the conjoint tendon.
And the floor is the foundation.
The floor is the superior surface of the inguinal ligament, the rolled under edge of the external oblique aponeurosis. Additionally, medially, this floor structure is stabilized by the lacunar ligament.
This architecture brings us to the most elegant piece of engineering in the entire anterior abdominal wall, the shutter mechanism.
Yes.
This explains how the body actively reinforces the structure precisely when it needs it most.
It's truly an aha moment of biomechanics. The body recognized that simply having oblique openings wouldn't be enough to resist, say, 200 pounds of pressure during a cough or a heavy lift.
Right.
The mechanism relies entirely on the relationship between the arching roof muscles and the rings.
How does the shutter activate?
When intra-abdominal pressure increases suddenly, the primary response is the powerful simultaneous contraction of the internal oblique and the transversus abdominis muscles, the muscles that form the roof and the deepest corset. This contraction creates two immediate protective actions.
What's the first action?
The muscles pull taut, causing the arching roof fibers to descend and flatten. They actively clamp down or shutter on the contents of the inguinal canal, physically sealing the space and making the canal aperture much smaller.
It clamps down. And the second action reinforces the back wall.
Exactly. That same contraction pulls the entire conjoint tendon taut, pressing this fibrous buttress against the thin transversalis fascia, powerfully reinforcing the medial section of the posterior wall.
Wow.
This dynamic action prevents the internal organs from pushing through the posterior weakness, which would be a direct herniation, or sliding into the deep ring, an indirect herniation.
So the body uses the very act of generating pressure to simultaneously trigger the defense system that contains that pressure. That is genius structural redundancy. But how reliable is that mechanism over a lifetime? Does the constant stress eventually wear out the conjoint tendon?
That's the crux of acquired hernias. While the mechanism is brilliantly designed, its effectiveness diminishes over time due to chronic, repeated strain and the natural weakening and atrophy of muscle and fascial tissue associated with aging.
I see.
In younger, healthy individuals, the shutter mechanism is robust. In older patients, or those with chronic cough or obesity, the fascial structures may simply stretch and fail, allowing the contents to push through even when the muscles are contracting.
The integrity of those fascial layers and the dynamic reliability of the shutter mechanism determine the health of the core.
Right.
When they fail, we get a hernia, a protrusion through the structural wall.
Right.
This is where all the anatomical details we just covered become clinically essential.
Hernias represent a mechanical failure, and the location of the failure is key to diagnosis and repair. We focus heavily on inguinal hernias as they are the most common, accounting for up to 75% of all abdominal wall hernias.
75%.
They are classified based on which ring or which wall they breach, specifically relative to the inferior epigastric artery.
Let's start with the indirect inguinal hernia. This often has a developmental component.
This is the most common type overall. The pathology involves abdominal contents entering the canal through the natural entrance, the deep inguinal ring.
Okay, through the front door.
Exactly. This means the hernia is always situated lateral to the inferior epigastric vessels. It follows the oblique path of the spermatic cord, often acquiring layers of fascia as its covering.
What's the root cause related to development?
It's usually associated with the persistence of the processus vaginalis, which is an embryonic outpouching of the peritoneum that normally closes off shortly after birth. If it remains patent or open, it provides a preformed peritoneal to sacca pathway into the inguinal canal, making failure inevitable under pressure. These hernias are common in younger males and frequently descend into the scrotum.
Yeah, compare that to the direct inguinal hernia, which is purely an acquired failure.
Direct hernias bypass the deep ring completely. They result from a failure of the posterior wall of the inguinal canal itself, a generalized stretching and weakness of the transversalis fascia and the conjoint tendon.
So it's a blowout.
It is. They protrude directly through a specific triangular weak spot known as Hesselbach's triangle.
And where is Hesselbach's triangle located anatomically?
The triangle is defined by three boundaries. Medially, the lateral border of the rectus abdominis muscle, inferiorly the inguinal ligament, and superiorly and laterally the inferior epigastric vessels.
The vessels again.
Vessels. Therefore, any contents pushing through here are situated medial to the inferior epigastric vessels.
So if the hernia is lateral to the vessel, it took the natural pathway, it's indirect. If it's medial to the vessel, it pushed through a weak spot, it's direct.
That is the ultimate surgical distinction. Direct hernias are overwhelmingly caused by chronic, repeated increases in IAP over time that overwhelm the body's static and dynamic defenses. They are typically acquired later in life and rarely descend far.
Moving beyond the inguinal region, we have the crucial femoral hernia. While less common overall, they are notorious for their danger.
Femoral hernias involve protrusion through the femoral ring, which is located just inferior to the inguinal ligament. The contents track into the top of the thigh, passing through the space created for the femoral vein.
Why are they considered so dangerous, especially compared to the more common inguinal types?
The femoral ring is bounded by tight, rigid structures, the inguinal ligament anteriorly, the pectineal ligament posteriorly, and the femoral vein laterally.
So it's a tight squeeze.
A very tight squeeze. Because the ring is rigid and unforgiving, any piece of tissue that herniates through it is highly prone to incarceration, getting stuck, and most critically, strangulation, where the blood supply gets cut off.
And that's an emergency.
Strangulation is a surgical emergency and is more common in femoral hernias than in any other type. They are also more common in women due to the wider bony pelvis.
Let's briefly touch on the other distinct hernia types of the anterior wall, starting with the very common umbilical hernia.
An umbilical hernia is a protrusion at the umbilicus, caused by the failure of the umbilical ring, which is the natural defect where the umbilical cord passes through to close completely. They are extremely common in infants and usually resolve on their own.
But they also appear in adults, typically due to strain.
In adults, they are acquired, related to obesity, multiple pregnancies, or conditions that stretch the central fascia, the linea alba. They can grow quite large and may contain omentum or even loops of bowel, requiring surgical repair.
A truly rare and often challenging type is the Spigelian hernia.
Spigelian hernias are fascinating because they are often diagnostically difficult. They are protrusions through a defect in the Spigelian fascia, the aponeurosis lateral to the rectus sheath, specifically through the conjoined aponeuroses of the transverse abdominis and internal oblique.
Okay.
They typically occur near the arcuate line where structural integrity is already diminished.
What makes them so hard to spot?
The key is that the outermost layer, the aponeurosis of the external oblique, often remains intact.
Ah, so it's hidden.
Exactly. The hernia sac is contained between the muscle layers and the skin. The patient has pain and swelling, but the doctor may not feel a palpable lump on routine physical examination. This is often referred to as a silent or intraparietal hernia, leading to delayed diagnosis and greater risk.
Finally, the acquired hernia is related to previous medical intervention. Incisional and peristomal hernias.
Incisional hernias are structural failures at the site of a prior surgical incision. They are a massive complication, making up a significant proportion of all abdominal wall repairs. They are caused by factors like poor surgical technique, wound infection, excessive tension on the sutures, or patient factors like uncontrolled coughing or obesity.
And they can get very large.
Enormous, requiring extensive reconstructive surgery.
And the specific type related to intestinal surgery.
The peristomal hernia. This occurs adjacent to an artificially created stoma, like a colostomy or ileostomy. Creating the stoma requires punching a hole through the entire abdominal wall, inherently creating a point of profound structural weakness. The constant presence of the stoma device and the pressure from the abdominal contents frequently lead to herniation adjacent to the opening, demanding complex and often recurrent surgical correction.
What this deep dive reveals is a masterpiece of engineering compromise.
It really is.
The anterior abdominal wall is designed as an incredibly robust, multi-layered corset, vital for our stability, pressure management, and organ protection. Yet, by necessity, it is riddled with structural flaws, the openings for vessels, nerves, and developmental structures like the spermatic cord.
The functional strength of this entire system hinges entirely on the coordinated interplay of those individual linens. We saw the absolute barrier function dictated by the attachments of Scarpus fascia,
By the internal dam.
the stabilizing crossweave of the oblique muscles, the life-saving redundancy of the epigastric anastomosis, and the genius of the dynamic shutter mechanism that uses contraction to prevent rupture.
The difference between a healthy, stable core and a site of major chronic pathology often rests upon the integrity of the transversalis fascia and the precise dynamic tension of the conjoint tendon.
It does. It's a profound reminder that stability is not just brute muscular strength, but rather a finely tuned, engineered balance achieved through fiber direction and fascial attachment.
It makes you rethink core exercises.
Yeah.
You aren't just building strength, you are maintaining the dynamic function of a mechanical shutter. For our final provocative thought for you, the learner, let's go back to the biggest structural mystery, the rectus sheath. We noted that it is incredibly strong above the arcuate line because the muscle is protected on both sides by aponeuroses, but structurally weak below, where all three aponeuroses shift entirely anteriorly, leaving only the thin transversalis fascia posteriorly.
The plywood layer.
Exactly. If the entire evolutionary purpose of the abdominal wall is to contain extreme sudden pressure, why did the design leave the lowest, most stressed portion, the segment proximal to the pelvis, so comparatively vulnerable?
That's a great question.
Perhaps the pyramidalis muscle, that small vestigial player that tenses the linea alba, is not so vestigial after all. Could its seemingly minimal action play an outsized, albeit poorly understood, role in reinforcing the absolute center line against maximum tension in that vulnerable lower segment? That's the trade-off worth exploring further.